Please be quiet. So, continuing in our series, we've discussed about women. Now, our next topic, I think it was adolescent that was mentioned in your this thing, but we'll study children first, and then adolescent, then we'll move to older people, and then disabled people. So, public health needs of children. Children again a very vulnerable population. They are the ones which have to be more focused because they have an entire life in front of them. All of you have survived childhood. All of us are adults because we decided to survive, because we were fortunate enough to survive some of the problems, some of the diseases, some of the causes of deaths which could not save the other people, other children that were there. So we have to first understand what are the determinants of child health, and these are obviously very more or less overlapping with determinants of health in general. But children, because of the process of being born, because of the process of being vulnerable, because of the process of being dependent, they have a certain different set of determinants which are more overwhelming as compared to simply the biological determinant that they are born with. What are the causes of child mortality? No murmuring in between, please. No talking. Second last, you want to stand up and go out? What are the causes of child mortality? What are the key interventions that might be there? And now in this ever changing world, what are the three mega trends influencing children's future? So, what influence your future maybe around 20 years back is very different from what will influence the future of children who are born today and maybe in 2050. So, you have to understand these trends and what can be done or what needs to be done for these children who are born today. So, like we already know, determinants of child health are social environment, the physical environment and biological characteristics. Obviously, the genetic makeup is the one which is going to determine whether the child is what kind of life that baby is going to have. Birth weight and prematurity. If you look at it, birth weight is a very important determinant of the future of any particular child in terms of health. So, whenever we look at a child, whenever we take the history at 1 year of age or maybe at 5 months and 6 months, the most important thing that we want to know is whether that child was born at term, whether the child was developed enough to come out into this world, and the second component is what was the weight of that child. So, a birth weight of 2.5 is considered a 2.5 kgs, that is 2500 grams, is considered as a cutoff for a birth weight which is okay. Anything which is less than 2.5 is considered as low birth weight. So, this value of 2.5 is something that you should remember, 2.5 kgs. So, a child which is more than 2.5 kgs is likely to have a better outcome in terms of his health, in terms of his survival, as compared to a child who is less than 2.5 kgs. So, birth weight becomes a very important determinant of child health. And secondly, the immune system development, obviously that is one of the biological characteristics. Obviously, there are many layers, many information that is supposed to be, that will be taught to you in the future classes when you become an MBBS and further on if you decide to become a pediatrician. But some of the most basic things that you need to understand about child health, what are the causes, that is what will be dealt in this particular class. Physical environment, the housing and living conditions, pollution, environmental hazards, nutrition and food security. Social environment is socioeconomic status, parental and caregiver support and access to healthcare. Now, there is nothing which can be given more prominence for any particular child or something which can be held back for any particular child. All of these factors are equally important to help a child survive and grow. If a child is born with a good genetic makeup, but if he has not provided a good parental and caregiver support, or his access to healthcare is poor, even if the child is of good birth weight, say maybe 3 kgs or maybe 3.5 kgs, if the physical and social environment is poor, then it is likely that the survival of that particular child might not be, or even if that child survive, he might not be able to attain his full potential. So, all of these factors are equally important when we talk about child health. So, when we talk about child health, there is age range that you need to understand. There is an age range that you need to know, and this will be used frequently, and this will be used across your medical education, that what is the perinatal period, which is 22 weeks from gestation that is after the conception, to 7 days after birth. So, how the child survives outside the womb is obviously dependent upon how the kind of environment the child had, or what was the the biological makeup, what was the environment that the child was provided inside the womb. So, that is known as the perinatal period. And when we talk about child health, you cannot simply cut off that whatever happened in the pregnancy was not important for that child. So, this perinatal period is also considered as a very important determinant or a very important time period for the child's survival and growth. So, what are the key epidemiological concerns that we are worried about when we talk about perinatal health is stillbirth, that is a child who is after attaining the period of viability, even if that child does not breathe, that is what is the stillbirth. Now, these words stillbirth, gestation, perinatal, these are very specific definitions in the medical terms, and they are very specific definitions epidemiologically. So, we should know that how many deaths are happening in the perinatal period to bring about any interventions that might happen in the perinatal period. So, these numbers are very important. Then birth asphyxia, if the child is not able to breathe when the child is born. Preterm birth complications and congenital liability. So, these are the things that might happen around the time of birth and before the child is born, which might determine the perinatal health of that, which might determine the health of that particular baby. The second is the neonatal period, that is from the birth, once the child is born till the age of 28 days, that is known as the neonatal period. Now, the neonatal period is one of the most important and vulnerable, maybe सबसे ज़्यादा vulnerable is the neonatal period. So, most of the deaths that occur in the children, that is around 50%, if you take about say 100 deaths occur in the infancy age group, that is from the age of birth till 1 year of age the child is born, about 50% of those deaths occur in the neonatal period. And in the neonatal period, if you take from 0 to 28 days, about 50% of the deaths occur in the early neonatal period, that is in the first 7 days. And in the first 7 days, if you take the maximum more than 50% of deaths occur in the first 48 hours. So, when the child is born, that is the most crucial and the most vulnerable period. And as the child grows, the risk decreases, but if your interventions have to be focused right from the child, before the child is born till the time the child is born, and afterwards, after the child is maybe 5 years or 10 years of age. And when the child attains 10 years of age, then you have the period of adolescence. That is another set of problems that we have to deal with. So, and the early neonatal period is known as 0 to 7 days. So, the neonatal period, the complications are about sepsis, birth asphyxia, prematurity, congenital anomalies, hypothermia and hyperbilirubinemia. These are the things that you have to look for, and these are the interventions, these are the problems that you have to deal with when you are dealing with the neonatal period. Now, when we talk about public health, what you need to understand that what you read in pediatrics, whenever you make a diagnosis, whatever you do, you have to understand what is more common. See, you might be very fascinated with reading diseases about the rare genetic disorders, or you might want to make a diagnosis which is very rare. But you have to understand that whenever you make a diagnosis, you have to always think about the commoner causes first, and that is what you will be trained to do. That if you are getting a patient of respiratory distress, you do not have to think about cystic fibrosis first, you have to think about pneumonia first. Okay? And these are the common causes which have been killing children for many years. We have been able to decrease that mortality over the years, but there is still a lot that needs to be done. Obviously, every child has to survive. You cannot say that, okay, let some percent of children, let them die, that is okay. It is not okay that any child that is born does not live to see his first birthday or see the many birthdays that might come to his future. Okay. So, that is the early neonatal period, and then we have the late neonatal period, that is 8 to 28 days, where we have again infections becoming a key determinant of health. Infections, maybe you have to understand sepsis, pneumonia and diarrhea. So, it might look like very simple that it is only pneumonia or it is only diarrhea, but pneumonia and diarrhea kills many children, although both of them are preventable. Both of them are infective causes, and it is a little sad to see that children continue to die because of these infective causes, because the interventions at birth or immediately after childbirth did not happen for those particular children. Then we have the post-neonatal period, which becomes a different set of problems, different set of determinants, where we have again diarrhea, pneumonia and malnutrition. Vaccine preventable diseases or vaccines are the most important tool that we have at our disposal to help children not die. Okay. And growth faltering and developmental delays. Under age 5 children, again if you make it a little broader, but we want to categorize them, under 5 children becomes a very important stage of children where we want to decrease child mortality. So, there are very various stages, various definitions, but when you look at it from the epidemiological point of view, when you look at it from the developmental point of view, under 5 is one separate age group, under then infancy is another separate age group, from infancy neonatal period is another separate age group, which have different interventions at different time periods. Okay. And infancy is infections, introduction of complementary feeding issues. So, when the child is supposed to be on mother's feed, that is breastfed up till the age of 6 months of age, that is the child is not to be supposed to be given anything else other than mother's milk from the time the child is born till the time the child is 6 months of age. So, after 6 months, when the child is supposed to be given feed which is outside the mother's milk, it is again there are many things around breastfeeding that you will learn in future your course. But after 6 months, it is the problems of what has to be given, how much has to be given, ultimately that decides whether that after 6 months whether the child is going to have good growth, good development and good survival or not. And again another age is toddlerhood, that is 1 to 3 years, preschool age 3 to 5 years. Then we come to the adolescent age, it is divided into early, middle and late, that is 10 to 13, 14 to 16 and 17 to 19 years. Some of you were adolescent when you joined your MBBS course. So, adolescent will be dealt in the next class, but these are the age groups that you have to remember. It is not acceptable that you do not tell that what is the adolescent age group, it is 10 to 19 years and it is divided into early, middle and late adolescence. So, which are the top 10 countries with the highest number of deaths in thousands for children under 5 years? Now, we calculate deaths when we talk about these indicators, which will come in your maternal and child health indicators when you read further on. We have the infant deaths, like we read about maternal mortality, we have infant mortality, we have under 5 mortality, we have neonatal mortality, we have perinatal mortality. For most of these, the denominator is usually the live births, because that is the most easily available a number that you have, and probably you have to calculate all of these indicators using live births as the denominator. So, even who is talking? Yes?
These are per capita?
These are 1000.
Per 1000.
Yes. So, Nigeria is 645, sorry. So, this India is around, obviously because of the sheer population that we have, but we are clubbed with countries of African countries such as Nigeria, Democratic Ethiopia, China 110, Indonesia 89, but India contributes to a large number of deaths. Yes.
Ma'am, if this has been taken, is this taking into account the population?
It is obviously per 1000 live births is going to depend upon the population that is there.
So it depends on, so it's not that India has a larger population, that's why it's higher on the list?
India has a larger population, that is why it is higher on the list, but in terms of when you talk about the chunk of deaths across, then India takes a big proportion because of the population also. If you take it across the number of deaths that are occurring across the globe, because of the sheer population of India, India takes a large chunk of those population deaths. So, the global under 5 mortality rate declined from 76 per 1000 live births to 2039 in 2018. About 5.3 million children under 5 years of age died in 2018, with nearly half of these deaths in sub-Saharan Africa. So, when we talk about deaths, it is child deaths, you have to think about Africa and the continent of Africa, which is having the largest mortality of children dying because of many causes in the childhood. Nearly half of these deaths are newborns, and a figure that will rise as the mortality rate for older infants continue to fall. So, our focus has always been newborn, but we have been able to bring it down, but ultimately as the deaths in the upper age group decreases, the proportion of the deaths in the lower age group, that is the neonatal death, that tends to increase because of the varying in the proportion. And the children in the sub-Saharan Africa are more than 14 times more likely to die before the age of 5 than children in Europe and North America. In Africa, it is, death among children is so common that people do not name their children before their first birth, before their first birthday. Okay, they say that it is not, it might not be a very useful thing to name a child because that child might not survive to see his first birthday. So that is how child mortality is, how common it is, because it is about 14 times more likely to die before the age of 5 than children in Europe and North America. So obviously the African children have a very poorer survival rate, and it is so poor, and because most of the children die in the first infant period, many African countries, it's a social tradition that they do not name their children even before their first birthday, because it is considered if they survive their first birthday, probably they will live longer, because survival at the first birthday is something that is not even happening in some of the countries in Africa. So what are the causes of these deaths? So when we look at this, these are the neonatal deaths, where we have about the major chunk is by preterm complications, by intrapartum related events, by sepsis, other injuries where congenital is common, tetanus, or even diarrhea in the neonatal death, that is up till 28 days. Although the child is supposed to be breastfed, diarrhea is not a very common cause of deaths in neonatal period, because the child is supposed to be breastfed, and the child that is breastfed is less likely to suffer from any kind of infection. And when you talk about the overall deaths, again it is pneumonia, congenital, malaria, injuries, measles, diarrhea, intrapartum related events, AIDS, meningitis. Some of these complications are the ones that are happening in the 0 to 59 months. When you look at these causes of child mortality globally, it is about with these are the infective conditions. These are the pneumonia, diarrhea, malaria, malnutrition and other causes. Southeast Asia, again we have the neonatal conditions, pneumonia, diarrhea, malaria, malnutrition. In India, it is the neonatal condition, that is which takes about 50% of the chunk of all the deaths that are occurring, and then malnutrition is one, diarrhea and pneumonia. So when you talk about child health, when you talk about deaths, you have to think about how to prevent diarrhea, how to prevent pneumonia and how to prevent malnutrition. This needs to be drilled into your brains by the time you become doctors, that when you are talking about child health, you have to prevent malaria, you have to prevent diarrhea, you have to prevent malnutrition, so that the child is surviving and not dying before seeing his 5th birthday, 6th birthday, or the birthdays that are to come in the future. So when we talk about this particular figure, a little complicated one, but you need to understand that we have made very good strides in decrease in the number of deaths that are occurring. It is not that nothing has been done, nothing has been achieved, because preventing pneumonia or preventing diarrhea, it does not require a big hospitals or very big ICU setups. You have to understand preventing deaths in children is as simple as it is the most low cost interventions, such as providing an oral rehydration therapy timely, maybe providing an oral antibiotic timely, maybe making a diagnosis of pneumonia timely. These are the simplest interventions that have actually led to a decrease in the number of deaths that have occurred over the years. Providing zinc. Zinc was a very important, a very important discovery, that adding zinc to oral rehydration solutions decreases the chances of that child dying from diarrhea. Adding zinc to a treatment of pneumonia or a treatment of upper respiratory infections increases that child to be surviving from pneumonia. So it is only these very simple interventions which have actually worked for the larger population to bring about a change in the number of children that are dying. It is not setting up big hospitals, it is not setting up ICUs, it is not setting up very big neonatal intensive care units. Obviously, it is not that it would happen before that, but the major chunk has been because of these simple interventions which were provided timely to these children. If you talk about ORS, please stop talking, stand up, get up. Yes. What is it that was so important that you needed to discuss when I am standing right here? No, you have to tell me. No, sorry. बताइए. What was it that was so important that you could not wait till the end of the class and discuss? Please get out. Out. Go. राजा है बुला रहे टेल मी व्हाट वाज सो इम्पोर्टेंट ये फुल स्क्रीन कर देना स्ट्रीमिंग भी मैंने रोकी थी डांटने के लिए प्रेजेंट ओके बताइए ये स्ट्रीमिंग हो रही है ना So if you look at this, you have the causes of child mortality, and these are the rates. We have been able to decrease these deaths per 1,000 live births over the years, and the number that you see over here that talks about the length of each bar represents the amount of change in all cause under the 5 mortality rate attributable to changes in the mortality rate for each of these causes. So we have been able to decrease these deaths due to diarrhea, due to lower respiratory infections, due to neonatal complications, due to neonatal in the interpartum period, due to malaria, but this chunk, that is preterm birth complications, intrapartum related events, neonatal tetanus, injury, congenital malformation, these are the ones which are still taking the major chunk of the neonatal deaths that are happening. So next we come to the second time period, that is from after the child survives his 5th birthday up till 14 years of age. Now what are the causes? In the countries such as Mexico, which are the lower, higher, the wealthy countries, it is the non-communicable diseases for the causes of mortality, followed by injuries, followed by other communicable, nutritional communicable diseases and the other causes. When we talk about countries such as Brazil, again it is non-communicable, followed by injuries, nutritional disorders and other causes. In India, it is still largely the nutritional and the communicable diseases. Injuries and finally the not communicable diseases are also becoming an important cause of mortality even in children in the 5 to 14 years of age. So like we always say, even if like in adults, similarly in children we are actually having the double burden of diseases. We have not been able to manage the causes of mortality, the communicable causes, but we are now having children dying because of non-communicable diseases in the age group of 5 to 14 years in India also, and injuries is also a very important subset of diseases of causes of mortality when you talk about this particular age group. For China, again it is injuries is the major one, that is about 53.4, followed by non-communicable diseases, followed by nutritional and communicable and the other causes. So now when we talk about what are the key intervention, what needs to be done, this is just a snapshot of what could be there, that might happen, that might be done to decrease these newborn complications from these newborn conditions. There are many interventions which you will read throughout the course of your MBBS, that what needs to be done to treat and prevent neonatal deaths, what needs to be done to treat and prevent infant deaths, what needs to be done to treat and prevent maternal deaths, what needs to be done to treat and prevent children dying after the age of 5 years, what needs to be done to treat and prevent maybe causes of deaths in adolescent. What could be the causes of death in adolescent that you could think of? That will come in the next class obviously, but any thoughts on that?
Normal infections.
Injuries, malnutrition. When we talk about these behavioral risk factors, these are the ones that are, and mental illnesses, that is a major chunk. When we look at the mortality and morbidity, which will come in the further classes, so you have to understand that what are the diseases that are killing the major chunk, and then only your interventions have to be designed according to that. So when we talk about, please stop murmuring in between. So when we talk about newborn conditions, we know that we have read this in the previous slide. It is the preterm birth, perinatal birth asphyxia, neonatal sepsis, low birth weight and congenital conditions. So these are the 5 conditions that you have to deal with, or if you have to focus on in decreasing neonatal deaths, then what needs to be done? What needs to be done at the preconception level, what needs to be done at the antenatal level, what needs to be done while the child is being born, and what needs to be done after the child is born. Sit down. What is your name? Rishi. So, the preconception is something as simple as giving a maternal folic acid or multiple micronutrient supplementation in the preconception period even before that child has been conceived. That might also determine that whether that child is going to survive the neonatal period or not, because preconception folic acid is given to prevent neural tube defects, way beyond before even that child is conceived. So, that is how you have to think about when we talk about, and this is what is known as the life course approach. Okay. And second is multiple micronutrient supplementation, obviously to the mother. A healthy mother is likely to give birth to a healthy child. That is what we have been saying, that is what we have been believing, and that is why whenever we talk about child health, you have to talk about maternal health. Whenever we want to talk about maternal health, you have to, it is going to determine the child health. Then the preconception period, nutritional supplementation with balanced protein energy in mothers at risk for undernutrition. So, what the mother is going to have apart from, in the preconception period is going to determine the survival chances of that particular child. So, a good nutritionally a fit mother is going to give birth to a child which is likely to survive. The chances of survival are more. Counseling or cessation of smoking, alcohol, and other substances. Smoking as an important cause of low birth weight. It might not be highly prevalent in our population, but it still remains a very important cause of congenital anomalies and very important cause of low birth weight or very important cause of IUGR in women where in populations where smoking is very, very common. We actually see women of your age group, we actually see women of maybe 20s or in their 30s smoking in public places, and it is a very alarming condition when we talk about smoking as a determinant of child health. So, it is something that you have to start thinking about and something that you need to know. It is not something that you can close your eyes to, that it is not happening in India, because whatever was happening in the West, it has started happening in our population also. Delayed age at first pregnancy and promoting optical birth spacing. Obviously, having frequent childbirths again and again is going to not give the mother's body to recuperate and provide and pass on the good nutrition to the baby. So, that is why these are the interventions that have to be dealt with even before. I am teaching you in the second semester of your year, and by the time you give your exam in the 7th semester that you will be giving, it is only these interventions again that we will be talking to you, because how these interventions were decided to be the most important ones, why these interventions, how they need to be given, and whether or not they are going to have an effect on decreasing the child mortality or neonatal mortality is something that you will read in your further classes of community medicine. So, I am just giving you an overview because it is as simple as writing routine antenatal care visits. Make all women to undertake antenatal care visits. But in a country which is so large in India, where we have stratification according to various socio-economic or various other urban rural or maybe north and south or maybe mountainous region or what should I say, the people living near the seaside. So, providing these routine antenatal care visits, just these 4 words, is not as simple as giving it to everybody and everybody getting antenatal visits and giving birth to babies. So, our entire public health is focused or built around these simple interventions. So, like I was telling you in the last class when we have this Janani Suraksha Yojana, it is these where we want people to we want women to deliver in healthcare facilities. One of the component is we want women to come to healthcare facilities during the antenatal period. So, women are very incentivized to come to the hospital so that they are examined during the antenatal period. They are told about the weight gain of the baby during the antenatal period. They are picked up for any complications that might happen to them. What were the complications that we heard about during the antenatal period in the last class? Anyone? 3 delays, but what were the causes of mortality in the antenatal period? Direct, indirect, any recollection? What were the direct causes? Hemorrhage, indirect causes, anemia. So, if you do not treat a simple thing as anemia in the antenatal period, the child is not going to grow properly and the child is not to be going to born of a good birth weight to survive neonatal period or to survive till infancy. So, that is how these simple interventions have come into the most important things. You have to have hospitals to treat women for obstetric complications, but you have to ensure that people come to the hospitals to get screened for these illnesses before they lead to complications and deaths. Then second is maternal vaccination against, all women are vaccinated against tetanus, so that the newborns that are born do not suffer from neonatal tetanus. So, if a mother is given tetanus vaccine during the pregnancy period, it is to prevent, because up till the adolescent age group all of you have had your TT vaccinations, है ना, आपके recently हुई होगी when you have given your 11th or 12th, that is the last vaccination that you might have received, that is 10 to 15 years, and when you come here you probably receive hepatitis B vaccination. Some of you have, probably you will receive that later on. So, something as simple as tetanus vaccination to prevent neonatal death, it needs to be given to these mothers in the antenatal period. Then where malaria is prevalent, if you want women to survive malaria, because malaria complicates, a pregnancy complicates malaria and malaria complicates pregnancy outcomes. So, a woman who is pregnant, if that woman suffers from malaria, he or she becomes a special case for treatment of malaria and he or she becomes a special antenatal case who have been suffering from malaria, that you will read when you study about malaria. So, intermittent preventive treatment is to be given for women who are living in areas where there is a high chances of that mother from getting malaria. Then infectious disease screening and treatment, all mothers have to be screened for the common infections that might occur, that is known as the torch group of infections during the antenatal period, so that the newborns that are born are survive. Then prevention of rhesus disease, that is Rh negative and Rh positive pregnancy. Then what needs to be done at the labor and the childbirth care so that the babies do not die, that is skilled care during labor and childbirth, that is all women have to be born in the presence of a skilled health professional. They are not to be, the children should not be born at home, so that their chances of survival are more. Care at the time of birth, warmth, delayed cord clamping, hygienic cord care and early initiation of breastfeeding. It might look very simple. Care at the time of birth is, there are 5 cleans, 7 cleans that you will learn when you want to understand, because the causes of neonatal mortality is, what was the commoner causes? Preterm births and sepsis. So, you have to take care that this care at the time of birth in terms of the delivery table, the cord, the cut with which the tie with the cord is cut, the thread with which the tie is cut, the area where the baby is coming, all of that are clean, so that you have less chances of infections. So, you know these are broken down into simpler interventions, so that we prevent these infections. Then then we have something known as delayed cord clamping. It is said that babies who are born after the birth, immediately the cord should not be clamped. You should wait at least 30 seconds, so that the baby receives that 10-20 ml of blood from the mother, and ultimately that will prevent the child from developing anemia maybe later on in the future. That is how these simple thing, that waiting for 30 seconds to 1 minute to clamp the cord is going to have long term benefits for the survival of that particular child. Then hygienic cord care is, once, because it was a very common practice, it still remains a practice. It has decreased over the many years, but after the cord was clamped, it was a practice to apply something on the umbilical stump that was there on the baby, and that ultimately led to a lot of infections. So, these are these simple cultural practices that have happened for many years, which have led to neonatal deaths, and it is focusing on these interventions that has brought about a decrease in the number of deaths that have occurred in neonates. Then early initiation of breastfeeding. A child should be breastfed and put to the mother's breast even before the cord is clamped. That is what is recommended. So, giving pre-lacteal feeds, giving complementary feeds, giving cow's milk, these are very common practices. When you go out in the field, if you go to the, the families that you go to, Just talk about what are the neonatal practices that are there. You will be surprised to the findings that you will come across, that what people do with babies once they are born. It is it is not always unhealthy, but some of those practices might be something like, it is a practice that the initial milk that comes out from the mother's wet is discarded, because that is not considered very good. But medically speaking, that is the most healthiest milk that can be given to the mother, because that is the most richest milk in terms of the antibodies that it provides. But it's a common practice to discard that milk, because it is considered that it is not the cleanest form of milk that can be given to the baby. So the milk has to be initiated, that the baby has to be put to the, because it's a natural phenomenon. It is a natural reflex that the baby is going to have, that he or she is going to has his sucking reflex once the child is put to the mother's breast. So the initially, the more even before the cord is cut, the baby is supposed to put to the mother's breast, and that decrease the chances of postpartum hemorrhage, which might lead to a maternal death later on, because of the oxytocin that is released when the mother is when the child is sucking on the mother's breast, that is going to decrease the the chances of maternal hemorrhage by terms of the blood vessels contract, the placenta separates, and it comes out fast. So these are the biological mechanisms that you will understand over the course of your course, which are ultimately going to be, and these interventions have to be put in place at various levels so that these deaths are reduced. And what needs to be done in the postnatal care is care during the first days and weeks after birth, including exclusive breastfeeding, that is anything other than breast milk should not be given to the child, not even water. Up till the age of 6 months of age, all children have to be given, all babies have to be given only mother's milk and nothing else. So please drill that into your head, and that is the most important intervention when we talk about preventing child deaths. Warmth, hygienic skin and cord care, vaccination and prompt care seeking for illness. When we talk about vaccination, we will vaccine preventable diseases is a different a class of diseases, because in fact diseases are classified. And secondly, despite of all these, obviously some children are going to fall sick, some children are likely to have some kind of infection. So when we talk about a child health, the earlier the intervention takes place, the better is the outcome, and that is there for all health, all diseases, but for children, and that becomes very, very important. And that is why for the children that are born, we have a lot of these community interventions, that even before reaching a doctor who might make a diagnosis of pneumonia, or who might make a diagnosis of diarrhea, or who might make a diagnosis of neonatal sepsis, some intervention has to be done for that baby before a diagnosis is made by a doctor, so that the diagnosis and the treatment given by the doctor is more effective. And that is why these prompt care seeking for illness is something which is the most important harbinger of care seeking when we talk about child health. That even before a doctor, we have community health workers who are not qualified doctors, they are only not even graduates. They have been trained, like if any of you is from a rural background, aapki ASHA or aapki auxiliary nurse midwife, these are the people on which the health system is on the shoulders of which the health system is banking upon, because they are the ones which are going to bring down the deaths of these children, not the doctors which are going to treat only the more complicated cases. As a doctor, obviously you will treat the complicated cases, but the major chunk has to be dealt with simple interventions such as identifying pneumonia, identifying diarrhea in these children once they begin happening. Okay. And these are the interventions which are supposed to take place these are the preventive interventions, and these are the treatment interventions that have to take place to prevent neonatal deaths. And obviously this is very, very these are only for the neonatal period. When we come to the infancy, when we come to childhood, these interventions are many, many more, but I am just focusing on the neonatal ones. Detection and management of hypertension, diabetes and fetal growth restriction during pregnancy. That is what once you have to, these are the preventive ones, and these are the early detection and treatment ones. So you have read about the primary and secondary prevention. So where will this come? Hypertension, diabetes and fetal detection and management. What kind of prevention would that be? Your thoughts? What is secondary prevention? A person who is coming to a hospital with some signs and symptoms, what kind of prevention you are doing? That's tertiary prevention. Whatever, if a patient presents with signs and symptoms, whatever you do, एक बार उसको बोल दिया कि मेरे को बुखार आ गया है, ठीक है, I have a sign of symptoms, I have cough. Whatever you do after that, that is only tertiary prevention. Secondary prevention is the disease is in the pathological phase, but there are no apparent signs and symptoms. So anything that happens before the appearance of signs and symptoms, that is secondary prevention, but the pathological process in the body has already begun. And anything that happens before the starting of that pathological process becomes the primary prevention. So obviously prevention is always better than cure, but not all diseases are amenable to primary prevention and not all diseases are amenable to secondary prevention. That you will read across, because prevention as such, primary and secondary, these are very this thing. But you need to understand that, but when the patient is coming to a hospital, what we are only doing is tertiary prevention. And what is quaternary? You have been taught about quaternary prevention? Prevention of diseases in the hospital. If a person is admitted in a hospital, prevention of nosocomial infection, that is what is quaternary prevention. A patient comes to a hospital to get healthy. If the hospital himself gives diseases to that particular patient because of many other reasons, then that prevention of that would be quaternary prevention. So you have to understand the spectrum of primordial, primary, secondary, tertiary and quaternary. Your focus, the training is largely tertiary prevention, but the focus of public health is largely primordial, primary and secondary prevention. Okay. Then you have these tocolicals, antenatal corticosteroids for preterm labor in appropriate populations. These are simple medical interventions that are given by doctors or maybe skilled health professionals, not even doctors, so that these deaths are prevented for the mothers as well as for babies. Antibiotics for preterm premature rupture of membranes to prevent infections. Detection and management of maternal group B streptococcus, helminthic, malaria, tuberculosis and HIV infections. Again, these are chapters or books itself on this thing. Kangaroo mother care and additional care of preterm and low birth weight infants, addressing feeding, warmth and breathing problems. Now this you will read in your pediatrics and this you will read in community medicine also, that a simple intervention of bringing a skin to skin contact for a baby that is a low birth weight is going to increase the survival chances of that baby. It is that the baby is kept between the breasts of the mother, because a low birth baby itself is a risk factor for poor survival. So even if these are the interventions that despite all of this, if we have a baby which is not up to the mark in terms of his biological or his other indicators, these are the interventions that have to be done so that the baby has a better chances of survival. Then cesarean assisted vaginal delivery, because cesarean sections might be indicated in some, not every baby can be saved by a simple vaginal delivery. So availability of cesarean section, availability of assisted vaginal deliveries in case of fetal distress at the right time and at the right place is obviously going to prevent deaths. Resuscitation if unable to breathe after birth. Resuscitation training for people who are present at a doctor cannot be present everywhere. So you have to ensure that the second cadre of workers are trained enough to bring about these interventions at the most lowest level of healthcare. Not every delivery occurs in AIIMS, not every delivery occurs in GMC Bhopal. There are deliveries that occurs across Madhya Pradesh and there are deliveries that occur in many of the villages in Madhya Pradesh. So if you want to prevent these deaths, it is not that you can tell people that okay, we will only build hospitals and then only your lives can be saved. You have to think of interventions where you can save the lives of the children even before building big hospitals and getting doctors to them. Then diagnosis and treatment of neonatal sepsis and local infections. So this will come across early diagnosis and treatment. Okay. So like we were discussing, what are the three mega trends shaping children's future? Now this is bringing the medical model into a more of, what should I say, the present and the future. So, this is taken from the state of the world children, that is 2024. What are the 3 things that are going to determine what our children, the kind of future and the kind of health our children are going to have that are born today? One is the demographic shift, that is fewer children are going to be born in some regions, increasing the youth population, but more children are going to be born in Africa. The climate and environmental crisis we read across the day in and day out, rising exposure to extreme heat waves, pollution and natural disasters. Children are the most vulnerable population when we talk about heat waves. Schools close when there are heat waves. Schools close when there are, when the temperature is below something, and all of these are causes of climate change. All of these are occurring because of climate change. Pollution that we have in Delhi, schools closing in Delhi, children having more illnesses in Delhi or in other polluted countries is because of climate change, what we have done. So, the future of our children, the future of children that are born today is largely to be determined by what we are going to do with terms for climate change in the future. And finally, frontier technologies, AI, digitalization and green technologies impacting education and health. So, certain details of this. The world child population will remain around 2.3 million by 2050. The population shifts is there will be increase in Nigeria, Ethiopia because of better survival. They do not have, when we talk about these why people want to have more children, it is because people used to have more children because the survival of their children was not very good, and again they wanted to have working hands to work in the field work that they were doing. So, it is people will start having less children if the chances of their children surviving is increasing, and in many of the countries that is what has actually happened. So, if you there is a very important interesting website, I am forgetting the name, I will share with you the next time, where you will understand that how demographic trends are obviously determined by the health that is being provided to people. And then the challenges aging societies in high income countries, impact of climate change, increased risk of asthma, heart disease, malnutrition, education, that is school closures due to extreme weather, floods and storms, displacement is millions of children forced to migrate due to climate disasters, and the positive impacts of technology. AI is impacting everything and it is likely to impact children also. Maybe you need more if you are interested enough, but AI and digital learning improve education, then vaccine advancement by way of whatever technology we have is going to change the survival of these children. Then green technologies enabling clean green solutions, ultimately having a change on the climate change. But there is still a digital divide. 90% of girls in the low income countries lack internet access, and privacy concerns and AI bias against marginalized children. So, these are the various issues which you will read across and read when you read further into community medicine. So, for today's class, just remember the age groups that are there, and you have to remember the causes by which children are dying and what needs to be done to prevent them broadly. You will obviously read about them later on. Okay. Any questions? Stop.